Welcome to ATCM, the Emergency Medicine channel. Shall we start, sir? A 66-year-old female presented to ER with complaints of generalized rashes and itching since last 2 days. On initial 10-second assessment, airway was patent, no pooling of secretions. Patient coming to breathing, respiratory rate was 18 breaths per minute, SpO2 was 99% on room air entry bilaterally equal, no added sounds. Coming to circulation, BP was 100 by 60, heart rate was 108 beats per minute. Capillary refill time was more than 2 seconds, and patient had signs of dehydration. Patient had dry tongue and dry mucosa, and capillary refill time was more than 2 seconds. So patient was initiated on IV fluids. Coming to disability, GCS was E4, V5, M6, but patient was not that cooperative because of continuous itching. Yeah. Coming to exposure, temperature was 1 degree Fahrenheit, and patient was initiated on antipyretics. Injection 1 gram IV stat. So, PCM 1 gram IV stat was given. Adjuvants to primary survey, we got a CBC CRP done, which showed a total counts of 9.1, HB of 11.5, platelet 1,70,000, CRP 206. Coming to VBG, patient pH was 7.404, potassium of 5, sodium 129, creatinine was 3.53, and bicarb of 18.3.
Creatinine was 3.53?
Yeah.
And acidosis was there?
Yes, sir. Her baseline previous creatinine according to the bystander was normal.
Normal.
Yeah. So coming to history of presenting illness, sample history, a 66-year-old female, known case of systemic hypertension, hypothyroidism, initially developed right-sided eye pain, burning sensation, redness and rashes over the forehead 1 week back, followed by eye redness, photophobia, blood vision. She was diagnosed with herpes zoster ophthalmicus outside and was initiated on medications, on antivirals. But later developed new skin lesions, itching and burning pain all over the body with fever, generalized tiredness and reduced urine output. With initial assessment and laboratory investigations, and according to the diagnostic criteria where the patient is having more than 20 vesicular lesions outside the primary dermatome and involvement of more than 3 dermatome, lesions crossing the midline, and also visceral organ involvement, we came to a conclusion that patient has disseminated herpes zoster with super added bacterial infection and prerenal AKI. On local examination, patient was conscious but was not that cooperative because of continuous itching. On local examination, right eye, patient had itchy lesions with rashes over the eyelids. That is vesicular lesions over the V1 dermatome. Hutchinson signs was positive, that is presence of vesicle on the tip or side or root of the nose, involvement of, it shows the involvement of nasociliary branch of ophthalmic division of trigeminal nerve. Then matting of eyelids was present, diffuse conjunctival congestion also present. Cornea was clear and iris normal, pupil 3 mm and reactive. Coming to generalized examination, patient had widespread itching lesions. CVS was S1, S2 heard, no added murmurs. On CNS, no focal neural deficits, no neck stiffness. Coming to respiratory examination, air entry was bilaterally equal, no added sound. Coming to GI, abdomen was soft and non-tender. So, with the initial assessment in laboratory, since we had come to a conclusion that the patient had disseminated herpes zoster with superadded bacterial infection, prerenal AKI, we had sent all the laboratory investigations, including pre-op serology, and the patient since then we'll come to the treatment part.
Right. So before that, so we have a case, 66-year-old female patient. Any comorbidities the patient had?
Type 2 DM and hypertension, hypothyroidism.
And hypertension, who's presented to you with already a diagnosed case actually,
yes,
with herpes zoster
ophthalmicus.
And now she's come with disseminated herpes. So it's one of those presentations of herpes zoster that is not very commonly seen. Disseminated herpes is not very commonly seen. So we should get to that. So before that, let's discuss about herpes zoster. Herpes zoster is a part of human herpes virus
3.
Human herpes virus family belongs to that.
Yeah.
There are around 8
8.
different viruses in this family. It's a double-stranded DNA. HHV1 and HHV2, which is herpes simplex virus 1 and herpes simplex virus 2, mainly causing oral and genital herpes, respectively, are the first two. Then you have HHV3, which is your varicella zoster virus. And varicella zoster virus, the primary infection, as we all know, causes chickenpox. And one thing about the viruses in the human herpes family is that they have a stage of latency. So latency is that period that happens after the active infection. These viruses migrate to specific areas. In your HHV1, as in HHV1, 2 and HHV3, what happens is they go into the nerves, right? So for HSV1, they'll go to the ganglions, and then your sacral ganglion for HSV2, and then for HSV3 they go to the dorsal root ganglion. So what happens is they are dormant. They are not going to shed their virus at all. But say you go over the age of 50 and your body is in extreme stress. Or you're in an immunocompromised situation, they can get reactivated. And when they get reactivated, it leads to manifestations like this. After HHV3, then you have HHV4, which is your Epstein-Barr virus, which causes your Burkitt's lymphoma, Hodgkin's lymphoma, nasopharyngeal carcinoma, infectious mononucleosis, and all that. And then you have your HHV5, which is cytomegalovirus, HHV6, which is roseola-like virus, which causes exanthomatous lesions in the fever patients in the infants. HHV7 is almost like roseola; it's called roseola-like virus. And then you have HHV8, which is your Kaposi sarcoma. All right. So that's something about human herpes virus family. And coming to our case of discussion here. So varicella zoster virus, initially it causes chickenpox, right? So chickenpox, how is it transmitted? By respiratory aerosol droplets from the lesions and all that. It initially infects your nasopharyngeal lymphoid tissue. It gets attached to it, gets circulated all across your body. It has various mechanisms through which it can evade the immune system. Before the lesion appears, it actually circulates in your body for quite a long time. So that is why it said that 6 to 8 days before the appearance of the lesion and 2 days after the appearance of the lesion, there is risk of transmission. Active shedding will be there, and the virus can be isolated as well. So normally they are vesicular lesions on an erythematous base. Okay. Various stages of these lesions can be seen all across your face, trunk, and your limbs. All right. So what happens once the lesions are forming on the skin, they are exposed to the sensory nerve endings of your skin. Eventually, they go a retrograde transmission, as in they move retrograde and they go to the ganglions and settle there once the infection subsides. Later on, what happens, there is a reactivation. When your body is under stress, it can be due to trauma, pregnancy, or an immunocompromised state like diabetes, or if they have some other comorbid conditions, or they are on immunosuppressant drugs, or they've undergone some solid organ transplant or hematopoietic stem cell transplant, and they're on strong immunomodulators. What happens is your body's immunity is down, defense is down. This time they get reactivated, and they have an anterograde movement through these sensory nerve roots. What happens? They go to particular dermatomes and cause the characteristic lesions. What are the characteristic lesions? They'll have these erythematous spaces, and they'll have papules, initially papules. So the characteristic rash that initially forms is their presenting symptom will be rash. Most of the time it's rash. The pain symptom or the prodromal symptom of fever, myalgia, and also the neuritic pain that we call an acute neuritis, whatever pain. The acute neuritic pain would be characterized as sharp, stabbing, throbbing, burning kind of pain. It is not very commonly seen, but if it is seen, it is seen in around 10 to 20% of the patients. Mostly it's rash. We should be very careful about how the lesions progress. So papules will be there. In a couple of days, they become grouped vesicles or bullae. After this, they become pustular. Sometimes from the vesicular or the bullae stage, they can go to the hemorrhagic lesions. If it goes hemorrhagic, you should always think about immunocompromised situations. Normally it's pustular, and after that they heal by hypopigmentation, scarring, or hyperpigmentation also. All right, so that should be noted. Now, say usually the lesions crust within 7 to 10 days or maximum of 14 days. But say after in these 7 to 10 days, another set of lesions are developing. The first set of lesions came, they subsided, but another set of lesions are coming. Now again, this also should be considered as, the patient should be considered as, mostly immunocompromised. You should work up for that as well. All right, this is how the lesions appear and disappear. We spoke about the acute neuritic phase as well. Basically, what happens, there is acute neuronal damage, nerve ending issues, nerve endings are disturbed, and because of that, microscopically, they say there is hemorrhagic necrosis of the neurons. This is why you get those symptoms, right? How are we going to address these situations? The most debilitating issue is definitely the herpes zoster, which is causing the issue, which we'll discuss about. But for the pain part, the first choice of drug that you give is NSAID. Normally, we prefer acetaminophen, initially first line that we prefer. And later on, if the patient continues to complain about pain, you can give a short course of pregabalin can be at, that's at a later stage. But you're supposed to apparently give a short course of opioid, short acting opioid, oxycodone is suggested. If the pain is very severe, the patient is not able to bear, say the pain scale is over 7 out of 10, then it is indicated that you can give a short course of steroids, but comparing, you should definitely weigh the risk versus benefit. They say prednisolone over a course of 10 days, 40 mg starting, and taper over a course of 10 days is what is indicated in the literature. Right. Now, we spoke about the pathophysiology, we spoke about the clinical features. One thing that we have to discuss and you should know about is the complications. Complications of herpes zoster. Can you name some dreaded complications that can happen in herpes zoster?
Neurological complications involve meningitis, encephalitis, and vasculitis.
Yes. So, if the solid organ is involved, the most common presentations would be meningoencephalitis. They can present with that. Aseptic meningitis is very common. HSV-related encephalitis is common, especially in immunocompromised. Then you can have herpes-related hepatitis, pneumonia also. And also, one thing that I failed to mention is about herpes zoster, ophthalmicus and Ramsay-Hunt syndrome. Few words about herpes zoster, ophthalmicus and Ramsay-Hunt.
Herpes zoster ophthalmicus is involvement of V1 of trigeminal nerve, which can cause keratitis, uveitis, and vision loss. And also can cause, like I told, Hutchinson sign positive.
Hutchinson sign. So as you rightly said, if any lesion, vesicular lesion you see on the side of the nose or on the root of the nose, it indicates that the nasociliary branch of the ophthalmic division of the trigeminal nerve is involved, which also supplies the globe. Because of which transmission would be easier. Alright. One more thing is, this is also what area?
Dangerous area.
The dangerous area. It is direct communication with the cavernous sinus. So these patients, you should always have a thought process of cavernous sinus thrombosis. In case their sensorium deteriorates or seizures develop or atypical symptoms develop, then you should always think about that as well.
Dreaded complication is definitely vision loss.
Vision loss. So early involvement of ophthalmology is important. What you can do from your side is supplement with artificial
ear drops,
eye drops,
and homatropin, cycloplegics, and all.
Cycloplegics are indicated, but we have to get ophthalmology consultation. Corticosteroids are indicated, but definitely get an ophthalmology consult before you start.
And also antiviral eye drops can also be used.
Antiviral eye drops, along with that, antibiotics are also
indicated for secondary bacterial infection.
Right.
Ramsay-Hunt syndrome is involvement of CNS nerves 7 and 8 with a triad of ear pain, facial palsy, vesicles in the ear canal or palate. Patient can also have
very important.
Causing hear loss and vertigo.
Hearing loss, vertigo, tinnitus. They'll have hyperacusis. All these issues can be there in Ramsay-Hunt syndrome. So, if you think about the facial palsy that normally happens, Bell's palsy. So here the facial palsy is more prominent, more severe it will be compared to the usual facial palsy that you see in Bell's. And just wanted to add that in case of herpes zoster ophthalmicus, eventually, one thing, if you don't take care of it at the right time, it also causes acute retinal necrosis as well
Yes, sir.
in the late stage.
Late stage.
Something that you should be concerned about. Right. The other complications, any other complications with herpes zoster?
Post-herpetic neuralgia.
Develops in about 20
20
to
30% of the patients.
Post-herpetic neuralgia, how are you going to address it? What is post-herpetic neuralgia? It is said that if the neuralgia persists for more than 90 days, okay, more than 90 days, the burning sensation still persists, then it should be diagnosed as post-herpetic neuralgia. How do we treat it? How do you address them?
Gabapentin and pregabalin can be.
Gabapentin, pregabalin, tricyclic
Antidepressants
can be tried. So that is one way of managing them, right? So how is herpes zoster diagnosed? Do you have to go to laboratory?
No, it's a clinical diagnosis.
It is a clinical diagnosis, but if at all you have any atypical presentations, then you will have to go for laboratory diagnosis as well. Very rarely though. So what are the laboratory investigation? What is the investigation of choice?
Either we can get a PCR from the vesicle fluid.
Polymerase chain reaction is the best. Go to diagnostic testing or direct fluorescein antibody testing can be done.
Or viral culture, but very rarely.
Very rarely. But PCR is the go-to test for this. Right.
Then with the complications, we can send all other laboratory investigations to see any involvement.
Right. In our patient here, she had suprarenal bacterial infection, a lot of skin loss as well.
Yes.
The patient was very much
dehydrated.
Not taking oral fluids also, a lot of loss from the physical barrier as well. So that's why she mostly landed up in
pre-renal AKI also.
And right. How are you going to treat this patient?
Sir, since we have a flowchart for the treatment, if the patient comes with herpes zoster, if no evidence of disseminated disease, ocular, otic or neurological involvement, and if all vesicles are crusted, then no treatment. If all vesicles are not crusted and if the patient is immunocompromised, if they are immunocompromised, if the patient is high risk for dissemination, for example, if the patient is hematopoietic stem cell recipient, organ transplant recipient with significant immunosuppression, such as those in pre or post transplant period or with graft versus host reaction, or patient presenting with chemotherapy and leukopenia, then we'll have to initiate IV therapy. Or for all other people, we can give oral therapy.
Oral therapy, okay. We'll discuss about the agents later, but let's go through the flowchart.
Okay. Then if the patient is not immunocompromised, but the rash started within 72 hours, we can directly start on oral therapy. If it is not started within 72 hours, then we have to look for any circumstances where treatment is still required. Like if the age is more than 65 years, a lesion in a location with complicated dermatomes, like we told Ramsay Hunt or ophthalmicus, V1 dermatome, or if there is presence of new lesions after 72 hours, then we have to definitely start, or else we don't have to start treatment. Then coming to oral therapy drugs, either we can give valcyclovir 1000 mg per oral 3 times a day, famciclovir 500 mg per oral 3 times a day, acyclovir 800 mg per oral 5 times a day. When it comes to IV drugs, we can give acyclovir 10 mg per kg IV every 8 hours. And in our patients also, we started on IV acyclovir with continuous monitoring of RFT.
RFT, very good. RFT has to be monitored. Which agent is preferred right now? What is the current guideline?
Valcyclovir is preferred because 3 times a day, more easy
regimen that can be practically taken by the patient.
Yes.
But also the oral bioavailability of famciclovir and valcyclovir is better. In pregnant females, which would you prefer? Acyclovir. Because there are more studies right now in the current scenario. There are more studies which gives safety data for acyclovir more than anything else. So in pregnant patients, this is preferred. Also, we should realize that any age group more than 50, immunocompromised status. And also if the patient had prior herpes zoster and it's a reinfection, the lesions are developing. After one set of lesions went off, the next set of lesions are developing. These patients are said to have more complications or post-herpetic neuralgia complications, or you should always think that these patients should be given an extra care because they can end up in severe complications later on. Right. So we had a case, an immunocompromised patient who we realized later presented with herpes zoster ophthalmicus to an outside institute, and they were treated, but she was getting progressively bad. She went into a pre-renal AKI, and then we had
superadded
bacterial infection. We had to hydrate her with fluids. We had to give her IV acyclovir, and we also had to start other IV antibiotics as well, and who's currently recovering.
Yes, sir, currently recovering.
Right. So
In
this
superadded infection also, if it is just a pustular infection, then we have to suspect only Staph aureus or Streptococcus
most common
pyogenes.
agents that get,
So we can start on augmentin or amoxicillin. But if the patient has severe involvement of organs or severe infections with fever, malaise and systemic involvement, then we'll have to hike up the antibiotics to piptaz and carbapenems.
All right. I guess that concludes our discussion.
Yes.
Thank you.
Thank you.